Happy Valentine's Day, you guys, and I hope you're doing well. I was doing some thinking and I thought, what would be a better way to celebrate than doing some practice board exam questions? So why don't we get into it? I brought you guys some snacks. We got these macarons, vanilla and raspberry flavored, so that'll be delicious. We've got some romantic candles we can light while we're doing some board exam questions. And even got a little letter that I'll read to you guys at the end if you stick around. So get ready to enjoy a romantic Valentine's Day board exam review night. I wanted to actually show you guys that I got this email back in September. So wow, it's almost been 6 months. But this person was telling me that they work at this marketing team for this company called MedStudy. And they're launching this new internal medicine Q bank. And so in order to promote it, they just asked me to, they just gave me a complimentary version of it. And, you know, this isn't sponsored or anything, but I thought maybe this would be the perfect opportunity to go through this question bank and see how it is. I actually did go through some of these questions a few months ago, and I did pretty poorly. So we'll see. Hopefully today will be a little bit better than the other time. But here it is. We are on the MedStudy website, and we have the internal medicine question bank. So let's start this session. Yeah, last session was January 4th. I did 3 questions. So let's get started, you guys. A previously healthy 32-year-old man cut his hand while working in the yard. Gram stain of the pustule shows no bacteria, but numerous neutrophils and some eosinophils. And then we go to the labs. He's got a leukocytosis to 18,000, some predominant neutrophils. His ESR is slightly elevated. Which of the following is the most likely diagnosis? Pustular psoriasis, acute generalized exanthematous pustulosis, or AGEP, drug reaction with eosinophilia and systemic symptoms, toxic epidermal necrolysis, and fixed drug erection. This is kind of how I like to do these questions. I like to read the first line, then kind of read the last few things and read the answers. And that helps you form kind of an idea of what might be, what they're going to be trying to ask in the question. And so when we go through this, pustular psoriasis is going to be somebody with very severe psoriasis. They're going to have a history of this, most likely. You're not going to get to 32 without having this. So far, this doesn't seem like this answer here. AGEP, acute generalized exanthematous pustulosis, you would see little pustules all over, and this generally occurs after a drug has been administered. And I have to actually look into the timing again. I believe the timing is around 7 days or so, but I know I have an Anki card on this. It's something I could look up later. Drug reaction with eosinophilia and systemic symptoms. Again, if somebody got exposure to an antibiotic, for example, for his cut, and then is starting to have fever and eosinophilia, he doesn't really have eosinophilia here, so this seems a little bit less likely. Toxic epidermal necrolysis is going to be basically an extension of Stevens-Johnson syndrome. Again, another antibiotic reaction, but this would be involving more than 30% of your total body surface area and would involve mucosal sloughing and things like that. And then fixed drug eruption, which would just be something that happens after somebody has a drug given to them, and they always get a rash kind of like in the same spot. So he saw his physician who prescribed cephalexin or Keflex. 2 days later, he awoke with a fever, malaise, generalized itching, and a rash. The next day, there were numerous small bumps on the extremities. Because of worsening symptoms, he returned to his physician for follow-up care. He has no previous or family history of skin diseases and is not taking any other medication. His parents and siblings are alive and well. Temperature is 101.8, blood pressure 122/80, heart rate 110, respiratory rate 34. On exam, the skin findings are shown. The mucous membranes, palms, soles are within normal limits. Neck is soft, supple, and non-tender. Heart is regular rate and rhythm. It's just a bunch of like fluff here that we don't really need to know. They even did a potassium hydroxide test, which shows no fungal hyphae. So for Gram stain of the pustule shows no bacteria, but numerous neutrophils and some eosinophils. So interesting that they have some eosinophils in here. I'm actually not sure what the answer is here, but I think we can kind of go through a process of elimination. So pustular psoriasis, I think we can rule out. Toxic epidermal, also we can rule out. So now we're left with DRESS, AGEP, and fixed drug eruption. Yeah, I'm actually, I might get the first question wrong here on this pleasant Valentine's Day, you guys. Because I know I have an Anki card on this that goes through the specific differences in like the time course of each of these entities. But I think AGEP may present somewhat acutely. It would cause more of a fever, and they even mentioned that there's a pustule. Here it's kind of hard to tell because the resolution is not super great. But I think this is probably the most likely answer. Fixed drug eruption, I don't think would cause so much systemic symptoms. And then DRESS usually takes a little bit longer to appear, in my opinion. And we're not really seeing any peripheral eosinophilia, even though there's some eosinophils in the pustule. So I do think this is probably AGEP, but I'm not totally sure. So I'm going to say I'm unsure, and we are correct. And 78% of people got this right. So this patient most likely has AGEP, a type of drug eruption based on the characteristic findings of widespread symmetrical non-follicular pustules on an erythematous base on the extensor surfaces and trunk. Concomitant symptoms include fever and leukocytosis. The rash can appear within 24 to 48 hours or up to 7 days after taking the offending medication. For DRESS, we talked about that peripheral eosinophilia, but they said this may be absent during the initial phase. And then fixed drug eruption most commonly presents as a solitary round or oval pruritic patch. It recurs at the same site after ingesting the offending drug. And then if we want to take a look at Anki, we can take a look and see what notes we have on this. But very good learning question for me here, because it really did test that knowledge of the differences between AGEP and DRESS and some of these other entities. Okay, so AGEP generally has onset after 24 to 48 hours, as opposed to a typical drug rash, which is often after 7 to 10 days. It's also associated with very elevated neutrophils, whereas DRESS typically occurs after 2 to 6 weeks. And so you see, I have four cards on AGEP, and you can take a look here at this image that DRESS, again, is 2 to 6 weeks. You've got a fever, lymph node enlargement, hepatitis, and then you should also see pretty more significant eosinophilia. So eosinophil is very elevated. Whereas AGEP is within 48 hours, so very, very much matching with this patient's presentation. Eosinophils can be slightly elevated, and you do have a fever and things like that. So great question to start us off. Let's move on to the next one right here. A 45-year-old woman presents to the primary care clinic with a complaint of redness, discharge, and a gritty sensation in her right eye for the past 2 days. The rest of the physical exam is unremarkable. Which of the following is the most likely diagnosis? Keratoconjunctivitis sicca, or KCS. This would be if somebody you thought had Sjogren's syndrome, or sometimes you can just get it from old age, but she's only 45. And it would be a little bit weird for it to be just in one eye. So let's take that out. Bacterial conjunctivitis certainly could be on one side. Allergic conjunctivitis and viral conjunctivitis tend to be... So allergic tends to be bilateral, first of all. So I'm going to say that's less likely right now. Viral conjunctivitis tends to be on one side as watery discharge and then often spreads to the other side. And then Neisseria conjunctivitis, that just seems very, very rare and very uncommon. So probably less likely at this point in time. So let's see if any of these match up with bacterial conjunctivitis or viral conjunctivitis. The patient reports experiencing crusting of her eye in the mornings and feeling that there's some, and she explains that it constantly feels like there's something in her eye. So crusting oftentimes can be associated with bacterial conjunctivitis, where it's like literally stuck together and there's just like yellow crust that's sticking your eyelids together. But it can happen with these other forms of conjunctivitis as well. She denies any pain, itching, or visual changes. The patient does not wear contact lenses. This kind of gives us a clue that it's not like a Pseudomonas. Contact lenses being a potential risk factor for Pseudomonas infection of the eye. Her vital signs are within normal limits. Her medical history is unremarkable, and she does not take any medications. Visual acuity is 20/20 in both eyes. Right eye shows conjunctival hyperemia and purulent discharge. So almost certainly this is bacterial conjunctivitis. Viral conjunctivitis, again, would probably be more watery discharge, and then oftentimes spreading to the other eye. So I would say this person probably has bacterial conjunctivitis and would definitely qualify for antibiotics. And you can see 65% of people got this correct, and 23% of people chose viral conjunctivitis. You can see basically they were talking about the same thing as I was discussing, but you can see viral conjunctivitis typically has watery discharge rather than purulent discharge. And then they're talking about Neisseria conjunctivitis tends to have severe signs and systemic signs. And then allergic conjunctivitis typically presents with bilateral eye redness. All right, you guys, doing well so far. Let's move on to our next question. A 73-year-old man presents to the emergency department after experiencing a 60-second bout of dizziness on the golf course. I don't know why, but recently I've been admitting a lot of patients with dizziness, like pre-syncope, syncope, vertigo kind of symptoms. And for some reason, the workup of dizziness is kind of both frustrating for me at the same time, but also kind of interesting. Like, I'm always very curious when a patient says they're dizzy, I'm like, oh, this is like interesting. Like, I need to figure out why they're dizzy. For some reason, it's so weird because a lot of times it's very non-specific and then we don't end up finding anything sometimes. But for some reason, when they have like dizziness, it kind of piques my interest, at least recently. So the patient was slurring his speech on arrival and his speech is now normal. Okay, that's a little concerning. Which of the following is the most appropriate next step in evaluation? MRI of the head. So looking for a stroke, essentially. Dix-Hallpike test. Transcranial Doppler. So Dix-Hallpike looking for BPPV, or benign positional paroxysmal vertigo. Sorry, I said that wrong. The positional and the paroxysmal are switched. Transcranial Doppler. Not really sure what that's for. I know in infants they do it to like look for like signs of hydrocephalus or signs of like increased intracranial pressure. CT of the head. This is almost like for sure, this is like the initial workup that anybody should come in if you're concerned for a stroke. The first thing you need to get is CT head. And brainstem auditory evoked potentials. That's if you think there's some sensory neural problem going on here. So he leaned over to pick up his ball when he felt a spinning sensation that caused him to become nauseated and sweaty. He sat down on the ground and felt better about 1 minute. He still felt dizzy when he stood up, and his friends drove him to the emergency department. He denies dizziness and nausea to the emergency physician. Past medical history is positive for atrial fibrillation and coronary artery disease, for which he had coronary stent placement 1 year ago. He's currently on atorvastatin, dabigatran, and clopidogrel. Vital signs include heart rate 75, blood pressure 135/88, and pulse ox of 95% on room air. Cardiovascular exam reveals an irregular heart rate. Physical exam reveals that his cranial nerves are intact. There is no focal weakness or sensory loss in all 4 extremities. So, so some of the things they're adding in here is probably a bit of a distractor to try and make you think BPPV. This whole spinning sensation, like that, and it's positional, right? That could go definitely with BPPV. But I think definitely given his history, they're starting to give you a lot of clues, like, this is something that you need to be more concerned about and need to rule out a stroke or a TIA or something like that. Especially when they're giving you, he's on anticoagulation, he's on dabigatran, he's got atrial fibrillation, he's had like known vasculopathic symptoms. He has CAD requiring a stent placement 1 year ago. So he's got vascular disease. He probably has atherosclerosis throughout, not only his heart, but also probably in the brain as well. And then the fact that he is slurring his speech on arrival. Again, the first thing you would do is going to be a CT of the head to make sure he's not having a brain bleed. And then, you could consider an MRI of the head after that to see if there was any like subacute or chronic stroke in the past. But at this point, it seems like most of his symptoms have resolved. So you're not really going to be calling a stroke code on this guy to put TPA or something. Dix-Hallpike test. I mean, if this was like a slam dunk BPPV, yeah, you could start off with the Dix-Hallpike test. But I think we have enough ammunition that he really needs to get a CT head first to rule out any other problems or any other emergencies that could be going on. So you can see here, 65% of people picked CT head, 12% picked brainstem auditory evoked potentials, which I don't actually really even know what that's testing for. So that will be good to review as well. So dizziness most commonly represents benign conditions, but should always be considered a possible symptom of cerebral vascular disease, particularly in a patient with known cardiovascular disease or with multiple risk factors for vascular disease. Given the patient's risk factors for vascular disease and associated symptoms of nausea and dysarthria, a CT of the head should be the next step in this patient's evaluation. Early identification of a stroke may facilitate thrombolysis with fibrinolytic therapy to mitigate neurological injury. So that's another actually good point, because sometimes if they have a huge stroke, the CT actually can see it. But I actually recently saw a patient who had a stroke recently, and they were saying that the symptoms were kind of mild at first, And then they were like, oh, we're not sure if we're going to push TPA in the patient. Like they discussed the risks and benefits with the patient. Like, oh, he could just live with this or whatever. But then they decided to push it. And thankfully they did, because about an hour afterwards, the stroke symptoms started to get a lot worse, and they started having a lot more weakness and slurred speech and stuff like that. And if they had waited, potentially he would not have been in the window for TPA anymore. So just because the symptoms resolve a little bit, you still could have worsening of the symptoms after that if they are having a true stroke. Transcranial Doppler is gaining interest as a rapid means of assessing stroke in the emergency department. However, it is operator dependent, and currently results are not considered definitive enough to direct acute treatment. So very interesting. I actually did not know about that. So very curious to see how that develops in the future. The Dix-Hallpike test is not indicated in the initial evaluation of stroke and should be used with caution in patients with possible vertebral artery disease, as hyperextension and or turning of the neck may result in injury to the vertebral arteries. MRI of the head is indicated when CT head is negative, but concern for CNS pathology it remains. And then brainstem auditory evoked potentials are designed to assess pathology in the vestibular system proximal to the cochlea that may involve the vestibular nerve or brainstem. Prior to MRI, BAEPs were often used in the evaluation of dizziness to identify suspected acoustic neuroma as a cause of dizziness. All right, you guys, and let's end that session here. Somehow we ended up getting 100% correct on the questions today, which I'm pretty happy about. And I think we learned a few things. So it's definitely a very, very great Valentine's Day board review exam question night. Okay, so so I did promise you guys I was going to read this letter to you guys. This is a letter to you guys for Valentine's Day. Thank you guys for your support and everything. But I really just want to express my appreciation for you guys. So here's what I wrote. Dear YouTube viewers, what a fantastic last few years it's been. Together, we've gone through residency, learned all sorts of various topics from cardiology to nephrology to critical care. We've reacted to Reddit threads, and we've also discussed how to improve yourself at teaching and also working with medical students. It's been quite the journey, and I am grateful for every minute you have spent alongside it with me. You've even stuck through the weirder parts of the channel, like trying to suction dent out of a car, or cooking sketchy fried rice, and becoming truly obsessed with minivans for a brief moment. I truly appreciate all your support and your kind comments, and you guys are 100% the reason that I continue to do this and why it is so rewarding to me. Without your guys' support, comments, and all of the nice things you guys say in the comment section, I really wouldn't have the motivation to continue making these videos like this. So despite not being able to make all the videos that you guys request and going on hiatuses from time to time, and being myself someone who is continuing to learn every day and not knowing all the answers all the time, despite all of this, you guys continue to stick by me and watch all of my videos. And one note that I added here is that it's impossible to know everything in medicine, but one thing that I feel like I've been able to rely on is your guys' support and continuing to enjoy watching the videos I'm making, and that's been something very, very helpful for me. So thank you guys so much once again for the amazing past few years, and here's to many more as well. Happy Valentine's Day, and I'll see you soon in the next video. Cheers!